Okay. Good afternoon, friends. Now, today we have a very eminent speaker, Dr. SACHIN JADAV, with us for the platelets, all you need to know. But before starting the session, and before Dr. Preeti Madam introduce our esteemed speaker, I would like to highlight the activity of the FFPI in brief. Federation of Family Physician Association of India is having almost more than 35 units across the country. And apart from the academic activity, we are almost doing 2 to 3 academic activities per month. And apart from that, we are also doing social activities like Buzurgo Ka Humsafar, and the many more are in the pipeline. And we are also celebrating the various days, like we have also celebrated No Tobacco Day on the 31st May. So we will try our best to raise the activity of the FFPI at the national level. Thank you all the speakers and the members of the FFPI for their great support. And now I request Dr. Preeti Madam to take the charge and start the scientific talk. Dr. Preeti Madam, please.
Thank you, Dr. Pragnesh. It is a pleasure to inform you all about Family Physicians Association Bangalore. We are here from Bangalore with none other than Dr. SACHIN JADAV today, who's going to speak on platelets. And we are regularly conducting academic activities once or twice a month and annual conferences, and also celebrate the Doctor's Day with the social gathering, that is with the couples and families. So these are the prime goal of Family Physicians Association Bangalore is academic activities. One of them is here today for all of you. And to introduce our speaker, Dr. SACHIN JADAV, I invite Dr. Geeta Lodh, who is a senior family physician from Bangalore and who was the past joint secretary of our team. Over to Dr. Geeta Lodh, who is also in the corporate sector.
Thank you, Dr. Preeti, for the gracious introduction. Good afternoon, everyone, and a very warm welcome to today's session. I'm Dr. Geeta Lodh, and I'm thrilled and honored to introduce the speaker for the day, Dr. SACHIN JADAV. He is an eminent hematologist with a wide array of medical achievements and academic laurels. Let me bring to light a few of his success stories from the multitude of his accomplishments, as I'm sure I won't be able to enumerate all of them due to paucity of time and the list being really long. So let me start at the very beginning. Dr. SACHIN JADAV has done his MBBS from Rajiv Gandhi Medical College, Thane in 2001, his MD in internal medicine from BJ Medical College, Pune in 2004, DM Clinical Hematology from CMC Vellore in 2011, Fellowship in Leukemia BMT, University of British Columbia, Vancouver, Canada in 2012, and a clinical attachment with Great Ormond Street Hospital, London, UK in 2013. His work experience is vast, and he has also held the position of a group in charge hematology and BMT at Global Hospital Group India from February 2013 to October 2017. He has been the consultant hematologist and BMT, consultant hematology and BMT at Maitra Hospital, Calicut, and chairman Matters Private Limited, group head at HCG Group of Hospitals from August 2019 to the present. His current roles include building a total of 13 BMT departments since 2013. He is a program director for the bone marrow transplantation for HCG Group of Cancer Centers in India. He is based out of our flagship program at Bangalore, and he is currently overseeing the following 8 stem cell transplant programs at an international level. That is HCG Bangalore, Mumbai, Vadodara, Ahmedabad, Vijayawada, Visakhapatnam, and Nagpur. He is a member of multiple societies like the American Society for Transplantation and Cellular Therapy, American Association for the Advancement of Sciences, International Ambassador Cancer Genomics, and a few more. an eclectic range of ongoing research projects in which Dr. Sachin is the principal investigator, which includes optical genome mapping for hematological disorders, open-labeled randomized control trial of sitagliptin with or without ATG and post-transplant cytophosphamide for GVHD prophylaxis, open-label randomized control trial of romiflostim for promoting early marrow recovery in hematopoietic stem cell transplantation. He has written multiple publications and conference presentations, a few of which are familial hypercholesterolemia presenting an intracranial xanthoma, management of classical Hodgkin lymphoma, utility of PET scanning, extracting maximum from cytogenetics in acute leukemia, and outcomes in financial disadvantaged patients with breast cancer in South India. These are just a few of his myriad achievements. And with that exhaustive and illustrious list of accomplishments, I hand over the arena to Dr. Sachin JADAV. The topic for today's presentation is platelets, all you need to know. A very pertinent topic, especially with the sudden surge in dengue cases. The added knowledge will help us in the diagnosis and the prognosis of these patients with a lot more accuracy and confidence. Over to you, Dr. Sachin JADAV.
Thank you for that detailed and kind introduction, madam. Thank you, Dr. Preeti, for the opportunity. Such a pleasure to present to all of you. And I'm going to start off with the conflict of interest as well as the overview of the talk. I'm going to talk about what is pertinent in your practice. I didn't want to give too much theory or some detailed clinical outcome data. We are going to focus on what exactly are platelets, what are the causes of high platelet count, what are the causes of low platelet count, and finally we will touch upon dengue and ITP, the two commonest platelet problems that you see in your practice. So if you actually look at platelets and even RBC for that matter, they are nothing but balloons. They are balloons because they have a cell membrane, right? There is no nucleus inside, either the RBC or the platelet. They have a cell membrane like that of a balloon, and like the balloon has air, RBCs and platelets have cytoplasm, and the cytoplasm has its organelles. Both of these have been uniquely created by nature to perform some functions. And what we know about platelets is that it leads to a clot. Now you can see this is a schematic of a clot where there are these fibrin threads. There are platelets. You can see these are activated platelets because they have spikes on the cell membrane. And in these fibrin threads and platelet, the RBCs and WBCs are entangled. This clot is essentially solidified blood, and blood is liquid. It flows through our arteries, veins, and capillaries, which are essentially pipes. And whenever a pipe is cut, the blood can leak out. And what the platelet does, along with the coagulation proteins, is it solidifies the liquid blood. And this solidification stops the blood loss. Whenever we look at the peripheral smear under the microscope, we see a lot of these RBCs, you see some WBCs, and these are the platelets, right? You can see they are of different sizes. Some platelets are very tiny, some platelets can be large. If you look at it more closely, platelet is a fuzzy ball, it's a fuzzy bag of cytoplasm. And this fuzziness is very important for it to do its job. How does it do its job? When we look under the electron microscope, we see that the platelet has a membrane. It is full of cytoplasm, and floating inside the cytoplasm, you have some granules. These are alpha granules and they are delta granules, which are important for coagulation. So platelets are a bag, and then floating inside the cytoplasm, you have these granules. So you see what nature has actually done is given us a balloon, and inside there are these granules which are packaged with some chemicals. And these chemicals are released only when required. It is fantastic. It's like you carry a toolbox and you take out from it only when something is required, right? So that's how nature has designed this. It does not have a nucleus, so it cannot multiply. It has these granules, like I told you, alpha and delta. And with that, it can lead to clotting of blood. Now, most of us have read the old theory of coagulation. You know, the theory of coagulation where we had the extrinsic pathway and the intrinsic pathway. Today, we believe that that is not the correct theory of coagulation. The theory of coagulation has evolved, it has developed, and today, the, the extant theory, the current theory is the cell-based model of coagulation. Now, you see what this cell-based means is you can imagine an artery or a vein or a capillary as a pipe, and the blood is flowing in it. Now, suppose, as per the extrinsic and intrinsic theory, fibrin is formed inside the blood, which is floating. Now, this fibrin will float away. As the blood flows, it will float away. So that fibrin has to stick to a cell. Only then will there be a localized clot. So today we believe that all the coagulation happens on the certain surfaces of certain cells. And this happens in three phases. The coagulation is initiated, it is amplified, and then it is propagated to form a proper clot. This clot happens from thrombin, which leads to fibrinogen, breaking down to fibrin, and thus a fibrin clot. Now, this is a small, again, an animation. Okay, you see, this is the interior of the blood vessel. It can be an artery, vein, capillary, anything. This is the interior. You see, the blood vessel is torn, and when the blood vessel is torn, below the endothelium is what is called as tissue factor. All right, this is the endothelium. Below the endothelium, there is tissue factor. Now, when this tissue factor comes in contact with coagulation proteins, the whole cascade starts. This is the initiation phase. Now, this thrombin then goes and attaches to the platelet surface. So, platelets are not only activating the coagulation, but the cell surface, the platelet cell surface. You see, that's why it's a cell-based coagulation model. All the clot forms around the platelets and around this subendothelium, right? So the clot gets localized and all of this fibrin cannot flow away. The clot is formed at this particular location. So you see that bag of granules actually helps to localize the clot, initiate it and localize it and cause a fibrin clot. Now, obviously, what do you think will happen when the platelets are high? Common sense. You will have unnecessary clotting, what we call as thrombosis. And this high platelet count, whenever it happens, if you see a patient's complete blood count, if you see a CBC, right, and you see that the platelet count is more than 4.5 lakhs, normal platelet count is 1.5 to 4.5 lakhs. So when the platelet count is more than 4.5 lakhs, we start thinking, hey, look, this patient's platelet count is high. Can I ignore it? Should I evaluate it? What happens if I ignore it? Can it just be a benign problem? Or can it lead to clotting? Can it lead to deep vein thrombosis? Can it lead to pulmonary embolism? Can it lead to clotting in the cerebral veins? What are the problems that can happen? Remember that lot of the majority of your patients who actually have high platelets are having a benign problem. They don't have a major problem. And that is the case because platelets are acute phase reactants. You know, like we say in any infection or inflammation, the ESR can go up, the ferritin can go up. Similarly, platelet counts can also increase because it just reacts. The bone marrow reacts to an infection, inflammation, and pushes out more platelets in the blood. And this reactive high platelet count can happen in iron deficiency also. So majority of the patients that get referred to us for high platelet count, the first thing that we see is, what is the ferritin? Is there iron deficiency? Is that iron deficiency unnecessarily causing a high platelet count? That's the first thing that we look at. The second thing that we look at is, does the patient have fever? Is there any infective focus? Is there an acute inflammatory condition, maybe SLE or other inflammatory disorders? All of these can cause a reactive increase in platelet count. However, if this persists for more than 6 weeks, 1.5 months, if the high platelet count has persisted for more than 1.5 months, we think, hey, maybe there's something wrong. I need to evaluate this patient because this patient might have a problem in the factory. Maybe there is a problem in the marrow and the marrow has lost control and it is unnecessarily making too many platelets. Right? So, when we get a patient with a high platelet count, we first see how long has this been. If it is less than 6 weeks, we don't do anything. Even if the platelet count is 8 lakhs, we don't do anything. We said, well, this is acute. Let's rule out iron deficiency. Let's rule out an infection, inflammation. But if it persists for more than 1.5 months, we say, no, no, no. We have to look at the factory. We have to do a bone marrow examination to see if there is what is called as a myeloproliferative disease or myeloproliferative neoplasm, such as ET, essential thrombocytosis. This, in a nutshell, is how we approach a patient with high platelet count. What about low platelet counts? And you see this much more than a hematologist sees this, because you have a lot of patients who come with, dengue fever or non-dengue, dengue-like viral illnesses. So you see this much more than we see. And all of us are worried that if the platelet counts are low, will the patient bleed, right? So now let's come to what are the causes of low platelet count. Low, like I said, less than 1.5 lakhs. High means more than 4.5 lakhs. So, first thing is we will, of course, repeat the platelet count because it may be falsely low. Pseudothrombocytopenia. And I'll explain this in some detail. How do we rule this out? We call up the pathologist and we say, can you please check a peripheral smear? Look at the manual platelet count. Okay? So on the peripheral smear, look for platelets, whether you have enough platelets. The machine may be giving a wrong, falsely low value. Another cause of the machine giving a falsely low value is that the patient actually has giant platelets. The platelets are bigger than normal. What is interesting is that machine cell counter, the Coulter counter as we call it, which gives you the complete blood count. It has a software. The machine can only count the cells. And based on the size of the cell, it will categorize the cell, saying, hey, look, if the size is between this to this, it must be an RBC. If the size is between this to this, it must be a WBC. And if the size is between this and this, it must be a platelet. Now, what happens if a patient or a normal individual, he or she may not even be a patient, is congenitally born with slightly larger platelets? Okay, like some of us are tall and short and thin and heavy. Similarly, our platelets can also be bigger and smaller. I showed you, they're varying sizes. So some people are born with bigger platelets, giant platelets. Now, if that falls outside the software value, then the machine thinks this can't be a platelet. This may be a dust particle. So it ignores it. It does not count it. Okay. So there are people in, excuse me, especially in Eastern India, which is what we call they have a giant platelet syndrome. That means they are normally born with, the whole family has slightly larger platelets. So the cell counter does not count these platelets. If you do a manual platelet count, they will have more than 1.5 lakhs. But if you look at the counter, it will show 40,000, 50,000, 60,000 because it is not counting the large platelets, right? So we will look for these two things and try to rule out falsely low pseudothrombocytopenia.
So sorry to interrupt, sir.
Yeah.
There is very less light on your face.
Oh, so sorry. So I will change my position. Is this better?
Yeah, better now.
Sorry, because the window behind me was too
Yeah,
dark.
yes.
Okay. So once we have established genuine thrombocytopenia, patient genuinely has low platelet, then the first thing that you will think of is maybe it's dengue fever, maybe it's malaria. And most of the time you will be right. The commonest cause of acute drop in platelet count in our country is a viral infection like dengue fever. Occasionally, what happens is it's not dengue fever. The platelets have been low for some time, and that's a problem because the patient's marrow is not getting enough raw material. So understand that the marrow is a factory. It's a factory which makes RBCs, WBCs, and platelets. Every factory needs raw material, and the raw material that the factory needs for WBC and platelet production, not just RBC, but also WBC and platelet production, is vitamin B12 and folic acid deficiency. So when we see pancytopenia, hemoglobin is low, WBCs are low, platelets are also low. Sometimes the cause is B12 folate deficiency, right? Raw material problem. Sometimes the factory is just empty. So you have given B12, you have given folate, but there are no workers in the factory. Maybe it's an aplastic anemia. And sometimes the factory is filled with bad workers, which means there is infiltration by leukemia, lymphoma, metastatic tumors. It's important to remember that this is the commonest cause, viral fever. This is possible, but we should know when to suspect aplastic anemia and infiltrative disorders. And I will come to that. Just some images of pseudothrombocytopenia. You see, I told you platelet, their job is sticking to each other and making a clot. So platelets are sticky. And some people, when we collect their blood in the EDTA vacutainer, the platelets stick to each other. They will form clumps, and that will give a false low platelet count. This happens in about 1% of normal individuals. This is one cause of pseudothrombocytopenia, can be identified on peripheral smear. Manual platelet count is required. No treatment is required for this. Second, I told you giant platelets. For this, this is the kind of printout that you get from the cell counter, automated cell counter. We look for this value, that is mean platelet volume. MPV, right? Like you have MCV for RBCs, mean corpuscular volume. We have MPV for platelet, mean platelet volume. This is a second cause of false low platelet count. Like I said, it is congenital problem. These are the normal platelets, and you can see these are giant platelets. This is what we see in people, normal people from East India. Very common in our country. 1/3 of the population in East and Northeast India have giant platelets. So, when I was in Vellore, we used to get so many patients from West Bengal, Assam, Odisha with low platelet count. First thing that we would do is look at the MPV, the mean platelet volume. Here it's too high, the cell counter ignores them as dust particle, gives a false low platelet count, and that too every time you repeat the platelet count comes different. One machine will show it as 40,000, another machine will show as 1.2 lakhs, because of the different software in the different machines, right? So we look at the peripheral smear, we look at the MPV, and there is a mutation in a particular protein called MYH9 which causes this. No treatment is required. They never bleed. Okay. Now, how do we identify which patient to evaluate? That's the next thing. You will do this at your end. You will do IgG, IgM, NS1 against dengue, right? 80% of patients, you will figure out this is dengue. The platelets go down and then they recover. You know that, Okay. What we would also request is look at the lymph nodes and liver spleen. Because if it is a leukemia or lymphoma, if it is a hematologic problem, there are infiltrative disorder, then the lymph nodes and the liver spleen might get infiltrated. So look for that. Speak to your pathologist. Say, hey, are you sure the platelets are really low? Are the RBCs okay? Is this TTP coming up? Are you seeing any bad cells, abnormal cells, which could suspect, because of which you could suspect a leukemia or lymphoma? There are some conditions which I will now tell you where you have to do a bone marrow examination. And most important is if you think this is not dengue, if you want to give steroids, you have to do a bone marrow examination before the first dose of steroids. You can give blood transfusion, you can give platelet transfusion, no problem. But before you give steroids, do a bone marrow. You know why? Because some lymphoma and leukemia cells can get killed by steroids and you will then miss the diagnosis. I have seen a patient, 16 years old boy, 1.5 years before he came to us. And this is just one patient, okay? We see this pretty routinely. 1.5 year history of joint pain, knee joint, elbow joint. Most of the pediatricians felt young boy, joint pain, JRA, juvenile rheumatoid arthritis, right? Juvenile rheumatoid arthritis. He then received steroids, got better because he actually had ALL, acute lymphoblastic leukemia. He received steroids, some of the cancer cells died. His pain improved. 6 months later, they grew again. Then he went to another pediatrician. Pediatrician thought, no, he has a relapse after steroids. Now let me give methotrexate. Methotrexate is chemotherapy for ALL. Again, some ALL cells went down. Again, he improved symptomatically. Again, relapsed. And 1.5 years later, when he came, because he had received multiple, he had received steroids and methotrexate multiple times. Now his ALL has become resistant to treatment. When initially he had an 80% chance of cure. So you see, we don't want to miss these diagnoses. I won't even blame the doctors because this is just so rare. Most of the patients that they see are JRA, right? So how do we decide which patients should we evaluate further? And over here, I want to introduce a concept called as high-risk cytopenia. What is high-risk cytopenia? This is cytopenia which needs investigation, whether low hemoglobin, low WBC, low platelet. Which of these patients should we evaluate? So first, if more than one cell line is affected, so just low hemoglobin, your clinical diagnosis is iron deficiency, B12 folate, no problem, go ahead. If RBCs and if WBCs and platelets are okay, only hemoglobin is down, sure, you can treat with your clinical judgment. But if more than one cell is low, so if WBCs are low or WBCs are very high, if platelets are also low, then you have to think maybe there is something else happening. Maybe this is not just nutritional. If the peripheral smear shows something abnormal, okay, if your pathologist writes atypical cells seen, don't ignore it. Okay. If you see there are too many WBCs, you are seeing immature forms like myelocytes, promyelocytes, don't ignore it. If the lymph nodes are large, liver spleen are large, if there is a recurrent problem, that means you've treated, you've even given transfusion, and again the hemoglobin has dropped. Or platelets were low, they improved and they have again come down. We need to investigate further, right? Similarly, there are some conditions where you may get a normal number, but they are not working, which means you see normal WBC, but the patient is getting recurrent infections, dental infections, UTI, recurrent cough, cold, fever. Within 6 months, 2, 3 times the patient has fever. Maybe the WBCs are not really working. Maybe there's something wrong with the factory. Maybe there is something wrong with the marrow. And you've given empiric treatment with vitamins, iron, the patient is not improving. Evaluate further. And any time you want to give steroids, look at the marrow. do not give steroids without doing a proper evaluation. They are not benign drugs. They have their own problems, right? So with all of these happening, these patients need further evaluation. They need a bone marrow examination. Sometimes if there are lymph nodes, breast lump, etc., we may even have to do a PET-CT because this may be metastatic cancer, which is causing low platelets. Okay. Now we'll come to two common problems that you see in your practice. First is dengue, second is ITP, and then we will open up for discussion. Why does dengue present with low platelets? Remember, here the problem is not production. The marrow is normal. Here the problem is consumption. That means the factory is working properly. It's making a lot of platelets. But these platelets are getting destroyed in the capillaries. They are getting destroyed in the microvasculature. And this destruction is not immune. It is not immune. The dengue virus damages the blood vessel. It damages the endothelium. So there are microthrombi around the body. Okay? It is not immune. Hence, steroids don't help. IVIG doesn't work. And that is why WHO says steroids will not help low platelet count in dengue. What about caripil, papaya extract? Well, I don't know. But there is some data which shows it actually might help. And I'm sure a lot of you have used this and seen that in patients in whom I use papaya extract, they recover faster. Trust me, there is some basic science data to actually support that. So by all means, use caripil, use papaya extract. It does not have side effects as far as we understand. And patients actually recover their platelets faster. Sure, you can do that. But when should you suspect that, hey, look, this is something different? This patient is not behaving like a usual dengue patient. What's actually happening? Now let's come to this beautiful diagram that I found in a WHO document published in 2011. Okay. Now you see these are the days of illness. The patient comes to you, the day of fever, onset of fever, second day, sixth day, eighth day, 10th day. We have all seen that temperature goes down. Okay. Platelets also go down. And by 10th, around 10 to 14th day, around 10 to 14th day, the platelets automatically start recovering because the body starts healing. The viral load goes down. The endothelial damage, the microthrombi go down, and hence the platelets start recovering. So, around between day 10 to day 14, you see the platelets recovering. And you also see the hematocrit going up because of, hemo concentration. You all know this far, far better than we do, right? So, what I am recommending is by the time of, the time period of more than 14 days. So if the patient does not improve in 14 days from the onset of fever, there is a problem. You need to evaluate further. Okay. There are some warning signs. Again, I'm referring to what WHO has told us that patient is worsening, vomiting, not taking adequate fluid, severe abdominal pain, neurologic problems, bleeding. Remember, you know this, most of the dengue patients, even if the platelet counts are 10,000, they don't bleed. So if they are bleeding, they might actually be going into DIC, right? If they have liver dysfunction, if they get secondary bacterial infection, these are all high risk features, right? And in those patients, you may have to evaluate further, especially, you have to manage them in the intensive unit. And if the platelets don't recover in 14 days, you have to start thinking of another differential diagnosis. What about transfusion? You can give transfusions, platelet transfusion if the platelets are below 10,000 without bleeding. If there is bleeding or if the PTAPTT is deranged, target 30,000. Okay. No bleeding, you can wait till the platelets drop below 30,000. With bleeding, with deranged PTAPTT, 30,000 is the target. So in patients who don't recover their platelet count in 14 days, do a bone marrow exam. They might actually be having, uh, you know, something other than dengue. Quite often we find that patients actually had leukemia and they were, They were never having dengue at all. What about steroids? Sometimes you give steroids and you see that the platelets are recovering fast, and data doesn't really show this. So if your patient's platelets are recovering quickly after steroids, there is something wrong. Either the patient was anyways in the recovery phase, or the patient has a different diagnosis. Maybe he or she has ITP. Okay. So what is this ITP? Let's come to IT. ITP is an autoimmune problem. Autoimmune means an individual's immunity, which are the police of our body, the WBCs, the immunoglobulins. The police are supposed to attack the criminals. The police are supposed to kill infections. Immunity is supposed to fight infections. But when the police starts beating up normal people, it's autoimmunity. When your own immunity starts attacking the platelets, it's ITP. When it attacks the thyroid, it is autoimmune thyroiditis. Similarly, this is an autoimmune phenomenon targeting the platelet. Yeah? Platelets drop below a lakh and there may be bleeding. There are actually antibodies which go cover up and damage the platelets. Okay. How do you evaluate? Like I said, ensure that it is genuine thrombocytopenia. Ensure that there are no schistocytes. Right? It is not TTP, thrombotic thrombocytopenic purpura, where you will actually see schistocytes. It's not dengue, it's not malaria. Do a marrow again before you start steroids. Look for other features of autoimmunity, such as direct Coombs test, ANA profile. Look for viral infections which can trigger ITP. HIV, hepatitis B, hepatitis C infections can trigger ITP, right? There are definitions, right? ITP can be acute and persistent and chronic. I'm not going to get into too much of this. What is important is knowing whom to treat and how to treat. We divide ITP into stable and unstable patient. A stable patient may have a platelet count of 2000 and still not have any spontaneous bleeding. You know why? Because when the platelets drop, when the immunity kills off the platelets, the marrow, the factory, pushes billions of platelets to compensate. It keeps on manufacturing more platelets. And these platelets keep on plugging the small capillary bleed which happen in the body. So the platelet count may seem less, but the body is making enough platelets to prevent bleeding. These are stable patients. Platelets may be less than 5,000, but they don't bleed. They don't have purpura. Okay, nothing. And then there are some unstable patients who, with a platelet count of 8,000, 10,000, they may have purpura on the skin. They may have purpura on the mucosa, which is very dangerous. Now, this is a high risk sign. If a patient has purpura on the tongue, buccal mucosa, epistaxis, genitourinary bleeding, gastrointestinal bleeding, CNS bleeding, these are all high risk features for IT. These are the patients which need very aggressive treatment, even if it causes side effects. Okay, stable patient, slow treatment. Unstable patient, aggressive treatment, because 1% of these patients will have a sudden death due to IC bleed. So, high risk features of ITP, wet purpura. That means purpura on the buccal mucosa, tongue, epistaxis, not mild epistaxis, major epistaxis, requiring transfusion, requiring packing, genitourinary, gastrointestinal bleeding, and intracranial hemorrhage. Extremely dangerous. There are certain guidelines. We follow the American Society of Hematology 2000 guidelines. And what we know is we give the first line treatment with steroid. You can choose either dexamethasone or prednisolone. Okay. We first start with Dexa. We start with 40 milligram once a day for 4 days for adults. For children, we give 0.8 milligram per kg per day for 4 days. Why Dexa? Because it works faster. You see, in 7 days, 73% of patients will have good platelet count. Whereas with prednisolone, only 55. However, by the end of 1 month, even prednisolone responses catch up. So if a patient has wet purpura, genitourinary bleeding, I'm going to give high dose dexamethasone, 40 milligram daily for 4 days. Very quick response, right? This is the dose. We then follow up the patient. If the platelets start dropping again, so the platelets go up to 1 lakh, 2 lakh with Dexa or prednisolone, and then again, second week, they start dropping. That means now I have to give second line therapy. I don't want to give steroids for too long. Sure, I'll try to reduce steroid dose, but I have to start something second line. Dapsone, anti-leprosy drug, is an immunomodulator. It works beautifully in ITP. Azathioprine, immunosuppressant. Danazol, which increases the production of platelets and causes some immunomodulation. Rituximab, which is a monoclonal antibody. And then you have erythropoietin to stimulate hemoglobin. You have thrombopoietin to stimulate platelet production, right? Thrombopoietin. It is a hormone all of us have in our body. And these two medicines are artificial thrombopoietin. They are called L-Thrombopag and Romiplastin. So we have started using this. This also pushes up the platelet count. Some patients need splenectomy, but this is rare in today's practice. Most of the patients can be managed with medical treatment, either an immunosuppressant or dapsone or rituximab and thrombopoietin analogs, such as L-Thrombopag or Romiplastin. We use this if the platelets start dropping once the steroids are tapered. We start the second line therapy. About 2/3 of patients respond. So 60-70% of patients will respond to each one of these. 1/3 will maintain the response. That means you continue the medicine, platelets will remain good. And we give this treatment for a minimum of 2 years because autoimmunity does not disappear immediately. It usually stays. So once we start second line, we continue for about 2 years. However, in the last couple, 3-4 years, what has come up is earlier we used to start one dapsone. If it doesn't work, change to azathioprine. If it doesn't work, change to danazol. But in the last 4-5 years, what we have understood is maybe giving a combination, multi-drug therapy will help more patients. And that's where a protocol got published in 2016. They called it a total therapy protocol. Very interesting. Low dose rituximab, dexamethasone, and the thrombopoietin analog. And you see, half the patients normalize their platelet count within a month, and half maintain good platelet count at the end of 1 year. So as of now, these are the best outcomes, right? So today, if we have a patient who can afford rituximab, because this costs about 10,000 rupees per week, 5 to 10,000 per week for 4 weeks. So it's a 40-50,000 just for rituximab, and L-Thrombopag cost about 30,000. So first month of treatment is about 75,000. So if somebody can afford, we say, hey, take this as soon as we diagnose. If somebody can't afford, then we try one after the other. And these are very cheap medicines. Most of the patients can afford. I mean, dapsone is not even 100-200 rupees per month. So depending on the affordability, we try to do what we try to do. And that's the end of my talk. This is a team which does everything. It would be ridiculous of me to say that I manage ITP or I do bone marrow transplant. It's a team which does everything. And together, what Madam said, we manage 7-8 transplant centers across the country and one center in East Africa, in Tanzania. Thank you so much.
Thank you, Dr. Sachin. Really engrossed. It was a very lucid and beautiful, wonderful presentation where you took us through everything very smoothly. As of now, there are no questions in YouTube. I've just been watching and nothing here. I have a question, sir. You said that low iron deficiency causes thrombocytosis or high
Yes.
platelets.
Yeah.
So there are people who have beta thalassemia carriers. I mean, they are beta thalassemia carriers. They have chronic iron deficiency, or rather, their hemoglobin is always low. We know the pattern. So in such patients, can you have high platelets for a very long time? I mean, always the platelets are high. We see it, you said 6 weeks, but we see it over years.
So in such patients, it's important to do the ferritin, and the cutoff is 15, 1-5, rule of thumb. If ferritin is less than 15, there is iron deficiency. We supplement iron for 6 months and gently the platelets come down. If they don't come down, then we have to look for other causes of thrombocytosis.
Okay. In spite of the iron being given, the hemoglobin maintained is never above 11, and 10.6, 11, 10.2. One of my relatives only. But always the platelets are high. Is that fine, or she needs to be evaluated?
So the hemoglobin will never go above 11 usually because of
Okay.
thalassemia minor. So we ignore the hemoglobin. As long as the hemoglobin will always stay between 8 to 11. They don't need anything specific. Give iron tablets to vitamin B12 folate level. If they are deficient, treat that. If the platelets are consistently about 4.5 lakhs, then we have to evaluate.
Okay. And continuously above 5 lakhs. So I will do the. So there are few questions. How we can interpret IPF?
Immature platelet fraction. I don't know. It is a new parameter that some new cell counters give. And if you ask the person, the company guy who's selling the machine, he will say, no, sir, our machine gives IPF. But as hematologists, we don't really look at it. It doesn't mean anything. It only confuses the matter. It tells us that yes, the marrow is working, but it doesn't really show much. It is not used for any diagnostic or therapeutic criteria actually in hematology. It's just a fancy number that the machine gives, but doesn't really help much in practice.
What is the importance of ITF investigation in dengue regarding prognosis and severity of dengue?
IPF?
Yeah, ITF, T for Tamil Nadu.
What is ITF? I don't know what is ITF.
Dr. Vinay Desai, you can tell what is ITF. In the meantime, we'll take the next question. Best time to give iron in respect to food and meal times?
I don't think we know the answer, and I'll tell you why. So iron causes a lot of gastritis. We all know that. In some patients it causes constipation. In some patients it causes diarrhea. Until now, we have been giving iron 2 times a day, 3 times a day, etc. Now, there are two issues here. One is the tolerance. I prefer that the patient tolerates the treatment more than anything because they have to take for 6 to 12 months. So, if somebody says, Doctor, if I take iron tablet after food, I am able to tolerate. I said, no problem, take it after food. Remember, if the body is iron deficient, it will suck out right amount of iron even if taken after food. Some people say, I take it at midnight, at night before going to sleep and I can tolerate it. I said, okay, take it at night. So one is the issue of tolerance. I tell the patients, do what with which you can continue treatment for 6 to 12 months rather than trying for 1 week and then stopping first. Second, there is some data that giving iron daily, 2 times a day, 3 times a day is actually not good. You see, the intestine has receptors which down regulate. So, if I am giving iron every day, the absorption actually comes down. And there is a small trial which shows that alternate day iron therapy is better than daily. Okay. So, nowadays, what we are actually doing, especially in patients who don't tolerate, we tell them, hey, look, don't worry, take alternate day. Take post food at night, whatever you tolerate. So it takes some time to figure out what every patient can tolerate. We start and then we see them after 3 to 5 days. And we actually give it a alternate day. And then, of course, about 5 to 10% of patients can't tolerate oral iron at all. In that, actually, Livogen is a good medicine. It is tolerated by majority. Livogen, ferrous fumarate, right? However, 10% can't tolerate anything, in them we give injected. So my thing is, look at what the patient tolerates, give alternate day, give for 6 to 12 months. And in those 10%, 5% who just can't tolerate, there are good injectable drugs available.
So what is the dose of iron? Someone's question.
Tablet
Yeah.
doesn't matter. You know, the body knows how much to absorb. Okay. The body knows, nature is beautiful. If it is extremely iron deficient, first few days, few weeks, actually the absorption is very high. You can give 2 times a day also, 3 times a day if the patient is tolerated. But after a couple of weeks, the iron absorption falls because the receptors are down regulated in the intestine. So later on, once a day, alternate day is also enough. Like I said, we don't know because this is an age-old problem. We really don't have robust uh, trials and data on this. But I try to give once or twice a day in the beginning, and then I change to alternate day after
Alternate
2 to
day.
3 weeks. Yeah, after 2 to 3 weeks. Yeah.
So that question about IPF was ITF was IPF only. So
Yeah.
you have already dealt with it. So
Yeah.
we'll come to the next question. One female patient with low platelets, iron deficiency anemia, treated with steroids and dapsone, rituximab. Still the platelets are low. Patient is stable, no bleeding diathesis. How do we manage this patient?
Can you please tell me again what all has
Yeah.
been given? Rituximab?
Rituximab and dapsone and steroids.
Okay.
Anemia
So,
and low platelets.
okay. So, step one, I'll ask, has a marrow exam been done? Because we have to establish the diagnosis of ITP by doing a marrow exam. We have to look for other autoimmune markers, direct Coombs test, ANA profile, etc. Now, assuming the marrow has been done, marrow is normal, diagnosis is ITP. Okay. We now have to see three things. Stable patient, not bleeding, may not really require L-thrombopag or romiplastin, the thrombopoietin analogs. Here we have to see whether it is a young boy running around, playing football, etc., where we, even if they are not having spontaneous bleeding, we give L-thrombopag or romiplastin to keep the platelets above 50,000 based on the patient's lifestyle. Next, is the patient steroid resistant or not? So some patients become steroid resistant, means you can give methylprednisolone 1 gram, the platelets will not budge. But there are others where the platelets will remain about 30,000 with a low dose of steroid. So in that case, see, in ITP, our goal is 30,000, not 50,000 or 1 lakh. For routine life, 30,000 is the goal. Now, if a patient's platelets go up with steroid, I bring it down to the lowest dose of prednisolone, which will help me keep the platelets above 30,000. And if possible, I give the steroid alternate day to reduce side effects. That's the second bit. Okay. So first, L-thrombopag, romiplastin based on lifestyle. Second, if steroid sensitive, give the lowest dose to maintain platelets above 30,000 alternate day. Third, we have to see for how many months was dapsone tried. Remember, all of these medicines take, on an average, 4 months to take action. Many patients are given dapsone, azathioprine for 1 month, 2 months, and then they are stopped. No, you have to give it continuously for at least 4 to 6 months before you say it is not working. Assuming dapsone was given for 4 to 6 months, next I will try azathioprine and mycophenolate. And if these two also fail, then we will go ahead with splenectomy.
Okay. How frequently one can donate platelets, sir?
So, if we are donating whole blood, right, as in a blood donation, then the usual rules, that is once in 3 months.
3 to 6.
If we are giving SDP, single donor platelets on apheresis machine, then I think the recommendation is up to 3 times in a year, if I'm not mistaken.
Okay. Thank you, sir. Does injection ceftriaxone cause low platelet count, sir?
Yes. So, there are a lot of drugs which can cause what is called as drug-induced thrombocytopenia.
Thrombocytopenia.
Cephalosporins have been known to do this. But having said that, if you actually look at data, these are just case series or case reports. Nobody really knows what percentage of patients do it. And we use ceftriaxone all the time in our patients who have infection. Usually there is something else that is happening in the patient and the drug gets falsely implicated.
Okay. So I'm combining two questions. Somebody's asked which injectable ion is preferable, ion sucrose or ion carboxymaltose, and the dose. How many doses can be given? How frequently it can be given?
Iron sucrose should not be used in today's practice. It can sometimes cause lethal anaphylaxis. So iron sucrose should not be used. There are three other drugs, iron polycarboxymaltose, iron maltoside, and then there is one more. Between these, there is nothing to choose. You can use iron polycarboxymaltose or iron isomaltoside. Both are, for all practical purposes, they are the same. Okay. So don't use iron sucrose, use any one of the newer injectable iron preparations first. Second, the dose depends on weight, less than 40 kg, more than 40 kg. So most of the manufacturers will say less than 40 kg, use 500 to 750 milligram. More than 40 kg, you can give 1 gram or 1.5 grams. The dose can be repeated after 1 week or 2 weeks. And you repeat it until, 3-4 times until the hemoglobin comes up. And then you don't need to do it unless there is ongoing blood loss or ongoing malnutrition, absorption problem. For example, I have a patient who has short bowel syndrome. So he had diverticulosis. Majority of his bowel was removed. So he has a short bowel. So for his whole life, every 6 months, he needs one injection of iron. Now that's long-term iron therapy for a absorption issue or a bleeding issue, right? Very often we get women with chronic menorrhagia. They need more frequent long-term replacement. Otherwise, majority of the patients, you give 2-3 times and their hemoglobin normalizes.
Beta thalassemia carriers also.
Oh, no, only if the ferritin is below 15. Otherwise, we don't have to give iron.
Okay, that's all the questions currently in the chat. And thank you so much for an excellent presentation and sparing your time to be with us and answer all our questions. I'm Dr. Sanjay has left us, so I will give the vote of thanks. Thank you so much, sir. And thank you all the viewers, all the colleagues who have joined us today to hear his talk. Thank you, Dr. Geeta. Thank you, Rochelle, and Dr. Pragnesh, who joined us in the beginning. Thank you very much, sir. I'm very glad you spared time for us. It was a very insightful talk which you gave. A lot of things are very clear now about platelets, especially considering dengue and other things. We have always been panicking the moment we see the platelet counts. And we knew
Pleasure
very
is
less about platelets. WBCs, RBCs, all covered most of the time. Platelets are less covered. Thank you so much, sir.
Pleasure. Pleasure is mine. Thank you. Thank you so much.
Thank you, Rochelle. Thank you, Geeta.
Thank you so much for a wonderful session.
Yeah, he's left, speaker left.
I'm telling you.
Thank you. Thank you. It was really good.